Oh, we're
Welcome,
live.
welcome. We're live. We're both staring at each other.
No, it was because I was making sure. Yeah, I was just making sure the hair was okay and everything. So I like blew up my screen to make sure everything looked good, and then I turn it down. And it's just you and I staring at each other. I'm like, oh shoot.
Just us. Here we are. Hi, how are
Hey,
you?
how you
I was
doing?
like, give me updates. Everything is good. I feel like this is like our Super Bowl in Houston as far as the weather. Like the weather's so amazing this time of year. So it's just like sunny and 75. I know a lot of folks are starting to get winter storms, and we're going to Chicago for Thanksgiving next week. So I'm like dreading leaving great weather for the cold, but you know, my little complaints in life. How are you? Give me updates.
I'm good. It's so funny. I totally said this. So I met up with Kim Quinlan on Sunday, and we went and got Greek food. And I forgot to text you a picture, and I was like,
Oh,
I'm not being an obnoxious Greek today. I didn't let Liz know I'm getting Greek food. But when you come out to California, we'll have to meet up with Kim. It's called the Great Greek. It's in LA, but it's a good Greek place. So excited
I would
about
love
that.
to. Yes.
How are you for the holidays? The holidays are all coming up. How are you feeling about that?
Feeling pretty good, you know, hanging in there. I feel like Callie and I just recorded a podcast yesterday on holiday stress and anxiety. So we're going to try to launch that next week so that we can get that out in a good time. Because I know that a lot of folks are indifferent and or feel really anxious or can experience a lot of depression and isolating kind of urges during this time of year. So just cognizant of that. But what about you?
Yeah, no, I'm glad that you're doing that live stream. And I always share things from you, from Allegra, from everybody in the field with my clients, especially my group. But we were talking about that. That was actually the theme. I'm moderating a young adult talk this Saturday at the conference about just feeling behind and feeling time lost. But we were talking about that in my group, and it's my adult group on Tuesdays. And we were talking just about, kind of like all the stuff that comes with having OCD. And one of the things that they were talking about is what's hard about the holidays per se is that you're meeting up with family and people are like, what are you doing? How is life going? And for a lot of people with OCD, they're struggling. They're in treatment. They're not working. They're behind in their classes. So, but another person was talking about, she bumped in from a friend from high school and, she's still living at home. She's getting treatment. She's doing great. But, just the embarrassment of having to be like, oh, I'm still living at home, So I think one of the things that I hope everybody watching recognizes is like, I think we put a lot of pressure on ourselves to sort of like fit the mold and hit those time markers that everybody else hits. But we don't have that expectation for people, let's say, going through cancer, right? Like if somebody had to take a couple years off of work to really treat their cancer or their physical health, we give them sort of a pass. But for us with mental health, there is no pass. It's like to ourselves. I think other people give us a pass. So we were just talking a little bit about self-compassion, being supportive of yourself, meeting yourself where you're at, and really creating and striving for goals versus judging where you think you should be based on other people's trajectory.
Yeah, exactly. No, 100%. And one of the things I was talking about as far as like my own anxiety and where it lives in the holidays is just I was actually sharing that being in the life stage I'm in right now with young kids and things, it's kind of easier for me to prioritize, okay, that needs to be the focus. But as I shared on this live stream, we're expecting twins in February. And so I feel really guilty about this holiday season not being as available to work and feeling like, oh, I'm about to like take big leave and leave my employees for, 2 to 3 months for maternity leave and not be as available during that time. And then the holidays just make it this like additional thing of feeling like I'm leaving people behind or that I'm, asking other people to pick up my slack. And that's a feeling I hate. So like, that's my own anxiety. And what I'm working on is like, how can I can be available. And like, even during the holidays, they can call me, I'm available to help. But like, the priority is to be with my kids as well during this time, so how do you kind of manage both? Which, as we all know, what treatment's all about before we hop in today is that reminder that all of us still get anxiety, and it may not be OCD focused, but like things still come up and things still feel uncomfortable or like not fun. And the question is can you work through that versus allowing it to stop you from being able to be present? So for me, being able to say, man, that's hard. And can I make sure our staff knows that I'm available if they need me? And I know I'll be in and out during this time, and recognize that that's hard, but I'm still going to do it because it's the value versus being able to, getting really stuck and then saying, okay, I can't go see family, or I can't be with my kids and can't do the things I want to do because I have to, be at work all the time. So being able to balance, I think one thing Callie and I talked about a lot on our podcast yesterday that I think is really important is I feel like so many times, Chris, people think anxiety treatment or OCD treatment means never being anxious again, or, getting rid of anxiety, where really what it means is, can you work through it? So like, instead of approaching the holidays, they're going to have anxiety attached, or that my depression might increase, so they're going to be bad. Can you have the perspective of like, yeah, I'm probably going to feel more anxious. I might feel more feelings of depression during this holiday season, and I know I can work through that.
Yeah, and what you said right there, I want to highlight the still having anxiety, because that is the number one question people will ask me after a talk, or if they get to know me, they're like, do you still deal with anxiety? And I'm like, of course, we all as people do. Anybody, ask your cousins, your friends, anybody with or without OCD or a diagnosis are going to still experience anxiety. It's actually our body's way of kind of giving us that sort of shot of adrenaline we need to push through difficult or uncomfortable or challenging things. So the goal of getting better is not to extinguish anxiety. It's learning to live with it. Now, obviously, as you get better, whether that's through medication or treatment or both, the anxiety isn't going to be as constant. It's not going to be as loud, and it's not going to be as in your face, right? Like, it's going to happen here and there, but it's not necessarily going to be as loud or as constant or for no apparent reason. But we all, as we get better, are going to live with that. And one of the conversations that I've had with people in a talk I've done before is like getting into the mindset to get better. And one of the mindset has to be like, I'm going to start to trust that I can navigate through and land on my feet when I experience anxiety. But I think if people go into treatment or holidays or life with this expectation of never feeling anxiety, that's typically when people are sort of checked out of life, not really doing much, because anxiety is just going to be a part of life. So it's how do we coexist with it and even thrive when experiencing it versus trying to get rid of it.
Totally. 100%. So let's hop in. All right, guys. So it is November 20th. We are 1 week away from Thanksgiving. We're not going to have a live stream next week because of the holidays. So this is it for us to talk about holidays, Thanksgiving, all the prep, all the things, and really just to make sure we answer your questions. So as you guys know, we host our live streams every Wednesday at noon Eastern, 11 Central, 9 a.m. Pacific. And we are here to answer questions live, but also to make sure that we give some good content and education that's always rooted in evidence-based interventions for OCD, anxiety, and related disorders. As always, a quick reminder, these live streams are not intended to replace individual therapy, and IOCDF and or our live streams are not a crisis hotline. If you're feeling unsafe or suicidal, please call 988, go to your local emergency room, or follow your local emergency services if you live outside the US. Please remember, our favorite part of live streams today is just Chris and I, so we're going to be chatting, is answering your questions. So we have a ton of pre-submitted questions that we always can hop into and start to answer, but our bigger goal is that you guys are going to put questions live and we can answer them as they come up. Just to give a little overview of some of our upcoming live streams, because Chris and I are super excited about them. In 2 weeks, so Wednesday after Thanksgiving, we're going to have Allegra Castens on. She is an incredible OCD advocate and clinician, and she'll be talking a lot both from personal and clinician lens. I can't remember a specific topic for that talk. Do you remember, Chris?
We haven't really talked about it, but I think we'll talk to Allegra and see what she wants to talk about specifically.
Yeah, so we're really excited though. Allegra's amazing, and it'll be a fun talk that you won't want to miss. And then after that, the following Wednesday, we're going to be having Dr. Eric Storch on, and Dr. Eric Storch will certainly be talking about all things related to OCD and OCD treatment, the latest research, but then also we'll make sure we pick his brain specifically on childhood anxiety and OCD and that treatment, since he specializes in it, and the integration of family into OCD treatment. So really excited about lots of our upcoming live streams. We've got a lot going on through the end of the year. So make sure you guys join. And of course, you can always go to YouTube as well and watch any of our live streams that you missed. But without further ado, let's hop in, and then I'll just say hi to everyone. Love you guys saying hi and sharing where you're from and what your weather's like. Thank you for the comment about my nails, all of the above. So fun stuff. First question, Chris.
Nobody commented on my nails.
Well, I love your nails, so I'll comment on them. So, and your hair looks great, and you're good to go.
Thank you.
Okay. How do you not let OCD and OCD tendencies negatively affect others, such as passing it on to children, people disrupting the lives of others, like taking too long, slowing them down, asking them to accommodate, all of the above.
Yeah, I'll let you answer the part about passing it to kids because obviously you have lived experience with that. I would say one of the biggest things that I talk to my clinician about when I was in treatment, and then one thing that I do with my clients is, when people are starting to discuss and talk about what are the things they want to address, one of the questions that I always ask is like, what are you most passionate about changing? Because we need to have motivation. But the second thing I ask is, are there any compulsions or any behaviors that really impact the rest of your family? Or maybe you're married and it's impacting your kids and your wife, or maybe you have roommates. Because when people start to get better and some of those changes include getting better around the way it impacts others, you start to get accolades from the friends and family around you. Like, thank you for being on time, or thank you for no longer asking me so many reassurance-based questions. So if you can identify some of the compulsions and some of the fixations you have that impact others, I think addressing that first with your clinician is a great idea. I did that and it made my life so much better. So it didn't mean that obviously all my OCD went away, but the things that were specifically impacting my mom when we were driving up to treatment, or my family I was living with, people started to comment on my success. They started to support me more, and there was less friction and fighting. But that's kind of our role in treatment, is to start to learn the tools and say, okay, I really need to cut back on my compulsions. I need to reduce. And part of that is going to be asking less reassurance, asking people not to open doors for you, or do you think I'm the kind of person that would hurt someone? So I think that's part of treatment, is reducing the way that it impacts others. And it's going to be a systematic and collaborative process.
Yeah, and then to answer the kid side, the reality is we can't control that. We can't control if our OCD might get passed down to our kids because that's more genetic. But what we can do is model, the way we've changed our relationship with anxiety. And what I will say is that if I was still really struggling with my OCD and my kids saw that all day, the way they would respond to their own anxiety would probably look very different than the way they do, right? But instead, I am constantly talking about doing hard things in our household, and when we feel anxious, doing it anyways, and being proud of ourselves and what that feels like, and really emphasizing those feelings so that I can start to set the groundwork for my kids around, hey, you actually can do hard things. You can tolerate distress. Anxiety doesn't have to be scary. It's not fun, but it doesn't have to be scary, and you can move through it. So again, we may not be able to prevent whether someone's predisposed to anxiety or OCD, but we can certainly think about ways that we can help lessen the impact that those symptoms that show up might have on their life.
Well said.
Next question, Chris. My brain is overthinking constantly, and I feel drained just from that alone.
Yeah, I mean, one of the things that we try to do at the foundation, I know Liz does it, I try to do it, is really educate people what OCD is. I know a lot of people understand contamination and a lot of people understand checking, but one of the things that I think the public doesn't understand is our brains are on fire. They're constantly working, they're constantly kind of spinning. And so what ends up happening is we do find ourselves overthinking. I think one powerful thing in treatment that everybody should learn is there's a difference between an O, the obsession, and a C, a mental compulsion. So if, let's say, you left the house and you were afraid that you left the garage door open, and maybe there's been some break-ins in town, and you're getting kind of anxious, and you're driving to work, and you get to work and you can't leave, and you're finding yourself just overthinking about your garage door being open. The thing is, the original obsession is the moment it kind of hits you. You get those chills in your body and you're like, oh my God, did I keep it closed? But the mental compulsion is choosing to spin on that. If instead of saying, hey, I'm at work, there's nothing I could do about it, it may have been left open, and if somebody breaks in, I'll have to manage that. But there's nothing I could do at this time. I'm here at work. I don't fully remember, and the more I'm trying to figure out, the worse my memory is getting about it. I need to push on, right? If you don't do something like that, the rest of the day, if at work you're just sitting there thinking about it, replaying your morning, trying to figure it out, that's what we call rumination, mental compulsions, and that's just as bad as like washing your hands or checking the stove. So what you really have to work on is, if you have no more information on the topic, instead of spinning on it, it's choosing to move on and sitting with that unrest and sitting with that feeling of like, oh, I'm not as sure as I'd like to be, but moving forward.
100%. And I think it's just so important to remember that, like, to also validate that, of course, you feel drained. Like, of course, we feel exhausted. Of course, we feel stressed when we're struggling with anxiety and OCD, because it's exhausting. Like, it's draining, it's stressful, right? Like, that makes total sense. And I think what's just so important, my little quick analogies, right, is that compulsions make us more confused. Solving keeps us more stuck. And so just to remember that like the more we overthink to try to solve, the worse we get and the more drained we feel. And it feels the opposite, right? Like our OCD tells us this lie that, oh, if I can just figure this out quickly, or if I can just get this answered, I'll feel better and be able to move through it. But that's actually totally a trap.
Yeah.
First question live today is from Spencer Albert at 1103. An OCD therapist quoting Julius Caesar said something similar to, "A coward dies 100 times, a brave man only once." Is this a quote that you might use with your patients?
Well, seeing as, wait, let me Google real quick. Is Julius Caesar, is he Greek or is he Roman, right? Because
if he's Greek, Chris will use it. If he's Roman, Chris can't use it.
He's Roman. No, we will
definitely Roman, Julius Caesar.
Right.
I love you.
Totally kidding. So obviously, the only thing I have a little bit is, no, I don't think anybody getting better from OCD is a coward, of course, but I like the basic theme of this quote. So basically it's saying is, if you're giving into the OCD 100 times, I wouldn't call you a coward. So we got to come up with a different word, maybe a scared person, etc. You know, when we give into the compulsion and we're afraid and we choose to do the thing that makes the OCD happy and not what's best for ourselves, the problem is you have to keep doing it and doing it and doing it and doing it over and over and over and over again. But when you make that brave choice and you say, you know what, I am not going to go back and check. I'm not going to pray one more time. I'm not going to check my growing to see if I'm attracted or not. I'm moving past that. That brave choice that we really want to start doing, it's creating a shift in the brain. It's creating a different relationship with the anxiety and the trigger, and that's how people get better. So I think the basic overarching message of this is great. Is like, if you choose to give into the OCD, you're going to do it 100 times. But if you choose to put your foot down, you start to nip that in the bud. You start to identify your core fears, and you start to get better.
Yeah, it's that analogy, right? Of like, do you want to have to feel like you have to face your fear every day, right? Or instead, do we want to face our fear and be able to have freedom from it, right? We talk about that all the time, that like when we're kind of facing it through rituals, we actually have to keep doing it. We have to keep being re-triggered, keep being reminded, and it keeps us really stuck. Where instead, if we can actually face that fear, you only have to do that once and you really can get freedom from it. Not saying you don't have to, you know what I mean? Like I say, I'm getting stuck for a second with my own words, because you don't do an exposure once and never have to do it again. But like, if you're facing it, once you've fully faced it, you only have to do that whole process one time because you've truly leaned in. Next question. Or Amy made a comment that I love at 1109. She just said, build the stress tolerance and emotion regulation muscle. It leads to resilience and empowerment. 100%. And what I want to say, Chris, is like, and just to kind of talk about for a second, is that this isn't just for OCD, right? This is for life. Like, think about a kid who learns how to walk. Like, they are falling all the time and they are not enjoying it and they're crying at first, but you're pushing them and motivating them, and eventually they do it and they're so proud of themselves. When you learn to ride a bike for the first time, and that experience, it's scary and challenging, and of course it's easier to just not do it. Yet at the same time, when you build that skill and you're able to do it and have this independence you didn't previously have, or this, you know, new fun, exciting skill that you get to practice and do, like it's so important for us to remember that this is a skill that isn't just about OCD and anxiety. It's a skill that applies to life, and to everything, right? When you are in school and facing a tough subject, like, you have to keep working at it, right? When you have a job and you have a tough challenge, you have to work your way through it.
Yeah, I mean, one of the things when I was doing my thesis in grad school is there was some research that showed that people with OCD struggle with emotional regulation, meaning that our anxiety and you know, our highs and lows are much more intense than the average person. And part of the beauty the research showed of ERP is it actually builds that ability to regulate yourself and to learn that if I push through and I take values-based steps, that I actually will have my anxiety be regulated versus dysregulated, which I think people mistakenly think. And distress tolerance is so important. I hate if anybody ever, because I've heard a couple people be like, you shouldn't have to tolerate distress. But the problem is that is life. And I think that's what you
keep life.
You keep coming back to, Liz, is like, my sister, my cousins, my neighbors, they all have to learn distress tolerance. I think a big one is, you know, I was on a plane coming back from being with you, And there's some turbulence when we left the airport. And it's like everybody on that plane had to tolerate that distress. Some people you could tell have flown forever because they're just like reading. But like the kids and like some of the people like me, you know, who don't fly as often, you're kind of just like, whoa, this is a little spooky. But you realize that you just get through it, right? You kind of grin and bear it, you manage it, you move forward. So I think these are both, Amy, thank you, skills that not only, you know, John Grayson talks about like after doing treatment, you're almost like a better version of yourself. But I think these things we learn that maybe even some people without OCD don't. And then when they get hit by real life situations, they're not always able to handle it.
Yeah, and I love what you said about the plane analogy, because it's important to think about like the folks who have been flying often and are used to that, right? They've actually habituated to that distress. But at one point it was distressing to them, but now it's not anymore because they're used to it and it doesn't feel any different than probably hitting a bump in their car when they drive, right? And so remembering that like the way distress impacts us is often different based on our experiences, right? Or our triggers. And that's okay. But can we learn to tolerate it? Can we build that muscle? And again, it's built over time. That famous saying of like, let's get comfortable being uncomfortable.
Yeah.
Yeah. So a couple people are talking about that and just kind of feeling like they need to build some distress tolerance skills that would be good for them. Nathan asked, if I have a kid, will my kid have OCD? You know, this is a good and tough question, because this is a question that I struggled a lot with for many years. The reality is that we know that you are more genetically predisposed to having OCD if you have a parent with OCD, because we know and believe that OCD has genetic components to it. However, what I will tell you guys, as somebody who for many years when my OCD was really bad, I had this like viewpoint of, well, then I'm not going to have kids because I couldn't do this to them. I have such a different perspective now as somebody who's both in recovery and has kids, right? My ability is that I can see when my kids have anxiety and teach them these skills early on. And it's so amazing to watch the way they can understand them and they can interpret them. And for me to be able to have pretty good confidence that they probably won't have severe OCD because they're learning how to apply these skills early on so that it doesn't have to get worse, right? What we know is that the earlier we intervene in any sort of intervention medically, the better the outcomes are as far as long-term impact on someone's life.
Yeah, and I would say one thing, because I get this question asked a lot, and obviously you have much more lived experience with it, but the thing that I always tell people is you're going to know how to identify it. You're going to catch it early. Somebody I used to work with who has OCD, she had a son who started to display behaviors, and she got it, you know, him in treatment right away. And he was able to manage his symptoms at a very young age. And so that's the one good thing. The other thing I'll say as well is a lot of times we feel that nobody else goes through things, or like I'm with somebody who doesn't have OCD, you know, but parents pass on genetic traits, genetic, you know, health conditions, other mental health conditions. So we don't want to ever make a choice not to do something because of OCD.
Yeah, 100%. And you never know. I've got one kid who has anxiety and my other one has complete opposite. So you just, there's no guarantee. You never know what's going to happen.
Listen, Bravery, we love it.
At 1117 from Kay Weaver, I work with kids with OCD. What are tips for knowing when to push clients further versus drawing back, especially when working with kids who use a lot of avoidance and rate things as really high or anxiety provoking? This is a really good question.
Yeah, one thing I always remind clinicians is that anything can be broken down. So if somebody is having a really hard time with something, right? So let's say, you know, I work with kids as well. I work with teens. I work with young adults. And sometimes, let's say, you know, a kid is triggered by something that their sibling's doing. They might have like emotional contamination. So if their sibling touches something, it's not that it's dirty, but they feel overwhelmed. And so the idea of, you know, the parents are coming in and saying, I just want my kids to be able to play together. Let's say that's just too intense for the child and it's just too much. Then one of the things that I would say is we can always break it down. So an example could be like taking a tissue and touching one of the toys that their sibling touches, and then, you know, rubbing a spot on the carpet in their room. And so that part of the carpet has a little bit of the contamination and they know it's in the room. They're not going to touch it yet. That's too tough, but just knowing it is a little bit. So I always say that you can break down harder challenges into smaller challenges. I find that kids do really, really well with structure. They do really, really well with collaboration. And so I'm, you know, I talk to my little clients like they're adults, right? I'm like, Tell me a little bit about, what do you want to learn? What is spooking you out? What are some things that you really miss and wish you could do? And I've had clients that say, my sibling feels contaminated, but I miss playing with them, and really kind of building that reason for them to do the hard work. I think sometimes, obviously, like our adult brain, and if you're a parent, as a clinician, it's hard because you're like, oh, I don't want to push. But one thing I've learned over the years, and this is really kind of the difference between how I was originally trained and how I treat OCD now, I felt like I pushed a lot in the beginning. I'll own that. I felt like I was the leader in the room and I was pushing people. And although I had great results, I found that people didn't feel like it was collaborative. And that's something I do a lot different now. I'm like, I'm not here to push you. I'm here to encourage you to push yourself. And so kids love rewards. They love feeling special. They love feeling like they're doing great things. And I would say, just checking in with the parents. Are you seeing a shift at home? Are you seeing results? Are they feeling a little bit uncomfy, but they're making thrives and they're able to, come back and enjoy the sessions and the work they do with you? It's like finding that Goldilocks, just right porridge.
It's just right porridge, yes. 100%. Which, by the way, Goldilocks, I saw this funny meme the other day that cracked me up, because it is like a story of parenthood where like mom's is way too cold because mom do everything else and they eat dead last, and like anyways, very funny. But
right, the dad's the first one eating, just chilling. It's
hot. The kids, we wait till it's just right for them, and then moms are dead last. So anyway,
dude,
like, oh, I get it.
I come over when I watch the kids, and I'm like holding the kids, I'm like eating, and my sister's like, do you want me to watch them all so you can eat? I'm like, we'll do everything. But yeah, no.
Yeah, you're like, I got those. Okay, next question. Hi there. Usually, how long can someone do ERP, and after ERP, do you switch back to regular talk therapy, CBT, or DBT work? And by the way, CBT is cognitive behavioral therapy, DBT is dialectical behavioral therapy.
Yeah, I know for me, this is just my personal experience, and then I'll talk more broadly. But one of the important things was getting some treatment after ERP. I felt like the ERP really handled the OCD. But one of the things I personally experienced was, because of trauma from the past, I had a PTSD trauma diagnosis from childhood. When I went and finished OCD treatment, that all kind of came to the surface. And I realized that I never had really handled that because the OCD was dominant. So for me, it was powerful to work on some other things that were in the shadows, because of the fact that OCD was so dominant in my life. And so what I tell clients is that if you feel once our work is done, I still feel confident using some of the tools that this person mentioned. But let's say somebody had a really challenging childhood and wants to go do, talk therapy for that, or maybe family counseling. That is definitely okay. Sometimes people ask, can I do both at the same time? I think it really depends on what's the loudest, right? If your family situation is so tumultuous that you can't even do ERP because your parents are getting in the way, there's home fighting, it might be something you have to prioritize. But I would say after, if there's something else, yes. I wouldn't ever kind of, rely on talk therapy, obviously, as a primary source of recovery for OCD. We know it doesn't help. But if you're looking for other things, I think it can be helpful if, a lot of people have co-occurring disorders.
Yeah, I couldn't agree more. So I will say, those of us that are OCD clinicians can also do other type of interventions, right? Whether it's supportive therapy or family therapy. But my clinician, who I've been working with for about 15 years, who I love, we don't do OCD work anymore, but I still go every other week, and we're doing more like family work and boundary setting and, kind of the challenges that come with motherhood and anxiety and all of the above. So she can definitely pivot. If you have a clinician, some OCD clinicians are really strict about like, I'm going to do OCD work and then you go somewhere else because I have a wait list. And so it totally makes sense. What I would say is, my indicator would be, are there any core fears that you still haven't addressed? Is there anything that you're still avoiding in your life because of your OCD? If so, we want you to really continue ERP for that before you move through it. Next question is, they said, first off, really appreciate all that you do for the community, and thank you. But the question is, in your experience, how big of a role does diet play in one's ability to recover and do ERP?
Yeah. I was fortunate to do a talk with Tommy Smalley. I can't call him Tom. I don't know why it doesn't come out. It doesn't roll off but Tommy Smalley, Krista Reed, and then my mom. My mom's a registered dietitian. So we did a talk at last year's conference about the impact. I spoke on sleep. I was trained with CBTI for insomnia, just about like the importance of sleep, meditation, mindfulness, exercise, and diet for your anxiety. One thing that we made super, super, super clear is none of those things I mentioned is going to effectively treat the OCD symptomology. And with that said, we want to be in the best state of mind, the best state of health to fight OCD. OCD is draining. As somebody commented earlier in their question, it is so obsessive and it's in our head all day and it weakens us, right? And so if you're finding, I know for me, what I tell clients is find what really impacts like your clarity, your wellness, et cetera. I had a client who with an IOP, they had a emetophobia, and it was a lot of fears about eating fast food because anytime they would eat fast food, they'd feel kind of sick and that made them triggered. And so we went and ate a lot of fast food. And we do 3-week intensives. That was the sluggish I've ever been in my life. I mean, I grew up with a mom who was a dietitian, so we had grapes for dessert. It gave away our Halloween candy. So just eating a lot of food like that for 3 weeks, I felt sluggish. I didn't sleep real well, etc. If I was at the height of my OCD, that wouldn't have been a good state to be in. So I'm not telling you that diet is going to in any way reduce anxiety. Sometimes people ask about like gluten-free. Obviously, if you have celiac, it's going to help. But yes, we want to do everything we can to be in the best space to fight the OCD. So if mindfulness and meditation, if punching a punching bag, if getting exercise, spending time with a pet, if those things keep you regulated and make you in your best mindset for fighting OCD, make that a priority. That's how I'd kind of say it.
I agree. Yes. What I always say is that diet and exercise are not treatment for OCD, but they certainly can help you feel better overall. And the better of a headspace you're in, if you're getting good sleep, if you're feeling good and healthy, the more you're going to be willing to do ERP, which is the hard work. Next question is, I struggle with ROCD, so that's relationship OCD in my marriage. A big compulsion of mine is avoiding. Exposures I've been working on are initiating intimacy, not necessarily physical, but things that trigger any sort of vulnerability.
Yeah, I mean, with relationship OCD, and it can also be with obviously non-romantic partners, but it is a big challenge in marriages and relationships. And so I think the good thing to work with a clinician is to really identify the way that you're addressing your obsessions. So this person who asked the question is saying that for them, a lot of it is avoiding. So that exposure is to work on initiating intimacy. I always think opposite action is like the most simplistic way to kind of figure out how to challenge the OCD on the physical side, the behavioral side. And so when you are, this person is putting themselves in that situation and they're actually initiating intimacy instead of avoiding, they're going to feel vulnerable. And one thing I talk to clients about is when you drop that compulsion and you're actually doing these values-based activities, right? This person initiating intimacy because that's a value for them in their marriage, you're going to feel vulnerable. You're going to feel reckless. You're going to feel, off. You're going to feel unsafe because our compulsions have conned us into thinking for so long that that's why we're safe. That's why we're stable. That's why we're in control. Like you said earlier, Liz, compulsions equal confusion. So this person's doing the right work. I'd say obviously cognitively, you want to make sure like while you're doing it, you're not sitting there and trying to reassure yourself, or you're not scanning, or you're not, going back and forth with the OCD, but fully leaning in and putting yourself out there and watching the shift in your relationship as you become more intimate and less avoidant.
100%. Yeah. So it sounds like those are great exposures, because I'm assuming by reading that they're values based and that that's a goal that you have that will strengthen the relationship, and that otherwise, if you listen to OCD, that avoidance is going to continue to cause strains on the relationship. Before we get to a couple other questions, I just want to answer a couple things. So someone had talked about efficacy of OCD, ERP for OCD. Actually, we know those rates to be much higher than 50%. They're often closer to like 70 to 80% are the efficacy rates for ERP for OCD. So it still remains the most effective evidence-based intervention with amazing outcome data and rates. What I always say is if ERP isn't working, instead of throwing ERP away, I want us to ask, why is it not working? Do I need a different provider? Do I need somebody who's had different training and background? Are they not really doing values-based ERP, an ERP that aligns with my values and motivates me, and maybe just having me do this more fear factor approach? Watch some of our YouTube videos on kind of ERP and what Chris and I have talked a lot about that, not about ERP not needing to be fear factor. But what I would really say is the intervention appropriate, in the sense that oftentimes we find that ERP frequency needs to be adjusted. So maybe it's not that ERP isn't working for you, but the once a week isn't enough. Maybe you need a higher level of care, like a residential program or an outpatient, PHP or IOP program, kind of be thoughtful about those different things. Also, somebody talked about how sometimes people can feel like they failed if they didn't do all of their goals. But instead, can we really reframe that to really look at all the other things you did do? And I think this is so important and such a critical topic for us to talk about. I don't know if this happens to you frequently, Chris, at the clinic, but for me, I find so many times, as other people are saying, that like we really are our harshest critics, and that our patients will show up and say, here's what I didn't do. And I'll have to say, can we actually start with all the things you did this week and all the amazing accomplishments right? Because it's almost like there's that OCD guilt of like, I need to talk about what I didn't do and I didn't accomplish this and I've let you down. And like this confessing sort of nature to it versus us being able to say, but like, yeah, look at all the things you did do.
Oh yeah, I remember even in my own case, my mom would point that out. She's like, "How come you always, when I ask you about something, you always tell me first all the things that went wrong? Why don't you stop for a second and talk about the things that went right?" And so we would talk about that. But absolutely, I mean, I see that all the time where people come in and they've made so many changes. They're going back to school. They're interacting with classmates. They're, driving again if they were having other people drive for them. And I think because of OCD's black or white nature, they'll come in and just look defeated. And so I'm thinking, oh, did they not really make any changes? Did they go back? Like, what's going on? And then when they share, I'm like, oh, the way you're feeling and what you've accomplished is so not equal, right? Like I'm hearing so many great things. And so I talk about like the seesaw balance. Like you got to if you're only going negative, you got to give me some things that are going to keep that seesaw balance. So I love the work, obviously, that Kim Quinlan has kind of championed in our field. I have her workbook. There's certain pages that I think are really great for this that I've printed out. And I'm usually at my office.
I was looking to see if I had it behind me to grab it.
I have it at my office. You can like see it in the background. I'm heading to my office after this. But no, I mean, I think there's some really good workbook pages in there. And the goal is to have people to start to see that, hey, if anyone else in my life were making these improvements in something, if they're cutting back on smoking or whatever it might be, you would be giving them the biggest high five. You got to start doing it for yourself. And even if it feels inauthentic at first, over time, you're going to it's going to start to be more second nature to actually champion the things that you're doing.
Yeah. And one of the things I find is that I feel like sometimes people think that exposures are not supposed to make us feel good, or that they're not supposed to include these positive kind of affirmations sometimes, that isn't true. In fact, actually, I find that a lot of times some of the best exposures are ones that are values based, right? So someone who has a scrupulosity fear of going to hell, instead of us doing exposures only on going to hell, can we actually do an exposure where we say, like, I'm really looking forward to being in heaven one day? And these patients will say to me, but Liz, I don't know if that's true. That feels just as scary. I'm like, yeah, and it feels just as scary, and it's aligned with your values of what you want. So like, let's do that one instead, because guess what? That one's going to actually make you feel good instead of make you feel more depressed or down. Next question from Ms. Lob is, in John Grayson's book, The Survey Method says, if you're not sure if something's OCD, ask someone close to you if they would do it. So ask them, is this OCD or not? Would you do this behavior? What do you think? Should I always do that?
Well, I think obviously in anything we can make it compulsive, but one thing I talk to clients about is, and what John Grayson talks about in his book is, a lot of us, and I can say this because it was me too, we are so far gone. And I think for me, when I was at my worst, I didn't even know what was sort of normal anymore. I didn't know what other people did because I had done OCD for so long that I was at a point where I didn't know how other people did stuff, right? And especially if your OCD can be around certain things like private thoughts, or maybe it's the restroom, right? We don't witness people doing it, and there's not a lot of information online. So one of the things I talk to clients about is a realm of normalcy, because we're all different, right? So if we take traditional contamination, you're going to have sort of like frat house over here, and you're going to have somebody that might have a maid and is pristine here, and then you have somewhere in the realm of middle of some people that are more on the clean side, less of the clean side. Obviously, you have out of the realm of normalcy on the dirty side, where people might, have cockroaches and things like that, and then you have the OCD side where people are bleaching things, etc. I talk to clients about getting in that realm of normalcy. As a clinician, my job is not to tell you how to live, right? How I live my life is not how you may want to live it, but is the motive behind what you're doing OCD based? If the answer is yes, we want to drop that and get in that realm of normalcy. So often that is part of the treatment, where people, an example would be, some people are part of a faith that I'm not a part of, and they'll tell me that they're doing these certain rituals, and I'll say, okay, I don't know if that's compulsive or not, because I'm not sure how your religion does it. Is there a religious figure? We can do it on a 3-way session. Is there somebody in your family that also attends the church? Let's talk to them and see what everybody else in the congregation is doing. And then the family member will be very clear. 3-minute prayer in the morning, 3-minute prayer at night. And then it's like, well, you're praying for 3 hours a day, so let's work on reduction. So sometimes it could be helpful, but once again, in OCD, we can make anything compulsive. So you don't want to do it on things you already have an answer to and already know.
100%. Couldn't agree more. Next question is, I'm Japanese and I have harm OCD for about 2 years. But recently I can cook and cut veggies. This stream has helped me so much. I still have some intrusive thoughts that come into my brain, but I love this. This is like why we do this work. So I love to hear and see that you are making strides that are tangible and you can identify those. So I hope you're enjoying those veggies and enjoying some of the different foods.
Yeah, I mean, Liz and I always appreciate the conference because we have people coming up to us and saying how much they appreciate it. But we love comments like this because it just means that the IOCDF is reaching people all over the globe, and that people from all different walks of life are watching it and getting better and learning from this and learning from the guests that we have on. So thank you. One thing I'll say is, like, it is a bummer, right, that as you continue to navigate your values and push yourself through things like being able to cook and prepare food, which is better than me because I have to microwave everything. I live alone. But, noticing that there are still going to be intrusive thoughts. But remember, the OCD wants you to engage with them. It wants you to challenge them or freak out from them or try to ignore them. And for me, what just worked is that bring it on method. So I had harm OCD in a little bit different way. Cooking and cutting wouldn't have bothered me as much, but around kind of like places where I could push people. And I remember as I navigated my treatment and I started like walking by people on the street or being near my grandma near the stairs, or if I was, near a balcony, being near people, the OCD would bring on those thoughts. And I just got really good at being like, bruh, like, it's just a lot of yap, and just not engaging with it. And it would pass because I gave it the cold shoulder. So bring it on OCD was always kind of my method. But yeah, we just love to see that you're living your values and continue to not, have that engagement with the intrusive thoughts. It's a lot of what if questions, a lot of maybes, a lot of that could be's. But in that moment, it's not happening. You're cooking and you're eating good food. So props to you.
Next question from Wiley at 11:30. Is there any optimal way to communicate that you have OCD to people who don't know much about it when you're in uncomfortable situations and it crosses your own stress threshold? And lots of people are saying great questions, so they want to hear this.
No, it's a great question because obviously you're asking it in a different way than we usually get. Usually we get people who will ask us like, how do I let people know I have OCD? But you're telling us, and this is a good question, is like, let's say you're hiking with your family and you're extremely triggered in that moment, or let's say you're in public and you're starting to have a panic attack, right? One thing I'll always say is it depends on the audience. If it's your friends and family that understand OCD, that's going to be different than maybe if you're on clients have told me like they'll be on a bus or public transport being triggered and kind of freaking out and people are starting to ask how they're doing. If it's people like that, anxiety is a better word just because the general public knows anxiety. So what I've told clients to say in that moment is just, oh, I'm having some anxiety, a little bit of a panic attack. I just need a moment alone for a second. And people will kind of back off and give you the space. But let's say it's like family. You're at Disneyland. You're really, really triggered. Obviously, Liz and I are therapists, so we're going to encourage you to push through, but we get that in that moment, you're experiencing a lot of discomfort and you may not be able to outright do the exposure, right? Like you're just trying to get through that moment. It's good to have these conversations with the people you love and know prior and just say, hey, if I'm triggered, I'm just going to let you guys know I'm triggered. I need a moment. For me personally, when I was triggered in public, I wanted to be left alone so I could kind of clearly think of my tools and push through. So what I used to tell my mom, because this happened a lot, I would just say, Mom, I'm pushing through some OCD. Just kind of turn on some music, focus on, I'm just trying to navigate that. So having a little prep conversation prior so that, they know what to do. Lastly, I'll always just give the warning. You don't want to make it a habit. I didn't want to get in the habit, for instance, with my mom that she always accommodated me. But yes, I agree. When you hit that threshold where you're like, hey, I'm not at a point that I can do an outright exposure. I need to kind of just navigate, get off that peak anxiety, having conversations with people you know prior. If it's people you don't know, just saying you're having some anxiety and panic and you're navigating through it and you just need some space.
Love that. And I love Beth sharing that you originally thought ERP meant you had to start at the highest, scariest level, but you learned that it wasn't. It was about really building your way up and feeling confident in ERP so that you could continue to progress. And that's how it should feel for everybody, you guys. Next question from Mr. Banerjee is, how is cognitive diffusion techniques of ACT effective for treating OCD symptoms?
Yeah. So cognitive diffusion is a great technique. We see it in acceptance and commitment therapy. And one of the things that it's doing is it's really kind of separating, right, like the thought from you. It's diffusing that. So an example, I was just doing a cognitive diffusion technique actually with body dysmorphic disorder with a client. And so one thing that would happen is they'd come in session and say, I'm ugly, I'm ugly, I'm ugly. And so what we worked on, as a diffusion technique, what about saying, I'm having the thought that I am ugly, or BDD is telling me that I'm ugly, or I'm noticing that I just had a thought about being ugly. And what that does is that creates some diffusion or some separation from your actual experience. It's not, I am ugly, or I am triggered, or my computer is dirty. I am noticing that I'm having the thought that my computer is dirty. And so sometimes there's other techniques. Sometimes people will say certain obsessions in a different voice or a different pacing. But mainly what I like clients to do is to be able to diffuse and notice that they're experiencing a thought, or even people talking about OCD as a separate entity from them. Sometimes with children, we'll have them name the OCD or draw the OCD. So it can be one of those things where, it's talking about the OCD as if it's a separate entity. We really, and I'd love to hear what you think, Liz, but acceptance and commitment therapy has been found to be a very, very good treatment. It wasn't designed per se for OCD, but a lot of clinicians are finding that there's so many helpful tools, and it works and pairs really well with exposure and response prevention. I have some clients that really love ACT. Some people don't love it. They're just like, Chris, I just want to hammer away at OCD. So as a clinician, we're always going to kind of navigate what the client wants. But I know for my own care, acceptance and commitment therapy, especially cognitive diffusion, was helpful. It reminds me a lot of mindfulness, and I was trained in that. So a lot of times if OCD said, your hands are dirty, I was like, oh, I'm noticing that I'm having a thought that my hands are dirty. And then it was easier for me to move past it.
Yeah, I couldn't agree more. I think that the only thing I just want to kind of reiterate is that a lot of folks will hear people talk about ACT being an effective treatment for OCD. But what our research really tells us is that ERP and ACT together can be an effective treatment. It's not necessarily more effective than ERP alone, but it can be an effective treatment. ACT alone has not been proven to be a standalone intervention for OCD. So you want to be pairing it, like Chris said, with OCD treatment. I think with ERP. I think most of us that are ERP clinicians, before we were really doing more ACT principles, as soon as we learned about ACT, we're like, oh yeah, we actually automatically already do a lot of this, right? Because a lot of the one of the ACT things is like leaves on a stream. Like, can you have that thought? Can you put it on the stream, acknowledge that it's there, but choose not to do anything about it and let it go away? That's actually very similar to ERP, right? Can you acknowledge the intrusive thought, but choose to not solve it, choose to not ritualize around it, and just let it be there, and it will eventually go away, and you'll get some distance from it. So lots of overlap for sure. Next question is, at what point is sharing one's worries or concerns or OCD themes considered to be a compulsion by itself? And I'll take this first if you want Chris to give you a breather. Sure. But I think that the answer to this is only you know. And so what I would say is, if you are telling somebody about your OCD or asking them about a symptom because based on that answer, it is going to alleviate or change your anxiety level, or because it feels urgent, like I need to know what they would do because that will then help me know if I can do this or not, if it's serving as reassurance, right? So if it feels like the question or the confession is going to change your anxiety level, then it's for OCD and it's a compulsion. If you're truly genuinely curious about something, then it's not a compulsion. But what I would say is, if you're genuinely curious about something, you shouldn't have to know that right away. That is something that you should be willing to tolerate uncertainty around and be willing to know later, right? So you'll get that question answered a little bit later, not have to have it answered immediately.
Yeah. I would say that's a big point, right? I always ask clients, like, what is the motive or the purpose behind what you're doing? Let's say you're sharing it because you're part of a support group and you're going to get support from the clinician and their fellow group members, and you're going to get some relatability. Like, oh, yeah, I've definitely dealt with that too. This is what worked for me. Amazing. If you're doing it more so, one thing I always tell people is, like, you're trying to reduce in the family of giving OCD an audience. You're trying to reduce having the OCD basically getting a stage and being able to speak. So a lot of times what I see in families is the person with OCD will talk about having OCD and go on, and everybody at the dinner table is listening, and there's not really any treatment happening. There's just sort of like this confession, just kind of spitting up about everything that they're going through, and everybody's like nodding along and listening. And if you think about it, that's an hour of just talking about your compulsions and not really treatment. So just be cautious about that.
100%. And then somebody else asked the question that I feel like without more context, it's hard to answer: OCD surviving. So what I would say is, like, that's something I want you to really talk to your therapist about. So if for you, there's specific examples where it's like, this is hard for me to differentiate, or I don't know how I could, like, it gets confusing. I want you to talk about those specifics with your individual providers so that they can help you tease this apart and understand what are the ways you should lean in versus not. And I think this is a great question, though, because sometimes people feel like, I need to lean into these things that I don't really want to live with or lean into. And so we really want you to work through that with an individual therapist.
Yeah.
We've had so many great questions, and I don't want to go over today because I think, Chris, I'm hoping we have 2 more questions that were pre-submitted. I think we should get to those. And then I was hoping we can kind of talk through our 2025 live stream structure and what that's going to look like. So let's start with one of the last 2 pre-submitted. What is the best way to lower the intense fears that come from OCD?
Yeah, I mean, I think there's a couple things you can do. Obviously, like, one thing I always talk to clients about is, if you want to, getting a assessment or seeing a psychiatrist about medication, potentially TMS, and there's a couple other options. But sometimes people's anxiety is so intense that they're in kind of like a constant state of fear, a constant state of anxiety. I know for me, medication was helpful in my process. I'm not on it now. I was able to get off of it. But for me, it was just, as I navigated OCD, I was going into a pure panic state where I could barely even focus on the treatment. And that's how we kind of came to that conclusion. But ultimately, one thing that Liz and I have always talked about, and I think somebody even made that in a comment, treatment should not feel like fear factor, and treatment should not be so overwhelming. Learning does not come from pure intense fear. So if the person is at that point where they're so anxious because they're in a constant state of panic in session, they're not going to leave and learn from that, because there was no learning that happened. They were in too much fear. So treatment should be systematic, it should be collaborative, but it should also be done in a way that you're not leaving so overwhelmed that you didn't learn anything. But one thing I want people to trust is, actually, as you start to face your fears and push through treatment, your fear and your intensity actually goes down. It doesn't arise like some people might think.
100%. And what I would also say is, there are some other tips and tricks you can do outside of OCD that are more in the DBT realm. So there's some what we call dive skills of, like, as long as you don't have heart issues, like holding ice, going on a 2-minute walk can regulate our emotions, listening to music. And so drinking cold water. So sometimes when someone's in the throes of a really big trigger, I want them to do a little bit of some outside behaviors before we start doing ERP that might help them get to a place where they will be willing to do ERP. Because if someone is so dysregulated that they're like, there's no way I could do ERP right now, we're going to get pretty stuck. So we want to be thinking about that. But overall, the best way to decrease your fears is going to be through ERP. Last question is, I have a question about existential OCD. Is depersonalization a symptom of existential OCD?
It absolutely can. So depersonalization and derealization, those are symptoms of a dissociative disorders. That's kind of the category they're under. And depersonalization is where somebody is experiencing such intense anxiety, instead of being overt and having like a panic attack, they're actually kind of shutting down and they feel disconnected with themselves. Sometimes people say, like, they feel like they're sort of like drifting and seeing themselves go through the motion, or watching themselves on TV. And I do see it paired often with existentialism OCD. So people are kind of asking themselves, am I even real? Am I here? Is this a simulation? So often I do find that this can go co-occurring. The good news is, often when we treat the existentialism OCD, the depersonalization does sort of kind of regulate itself and start to dissipate. But even more importantly, there are tools for depersonalization. I don't have it with me because it's at my office, but I actually have a book by Fugan Nezaroglu about how to treat depersonalization. It's a great book. I got trained in it. And one of the key components is very similar to ERP. You're really asking yourself to not go to an extreme and fixate on how you don't feel connected and panic. And you also don't take the opposite and try to like ignore it and get out of it. It's really sitting with that feeling, that sensation, navigating things anyways, and watching that feeling sort of dissipate as your body lets go of it. But treating the OCD is going to help manage that for sure.
100%. All right. Well, this has been an amazing live stream. We love being here with you guys and feeling like we get to both answer questions and just connect and be together. So please make sure you guys are joining for all the live streams. IOCDF works really hard to have live streams on both Tuesday evenings at 7 Eastern and, of course, Wednesdays at noon Eastern. But we have a little bit of announcements, I would like to say, around some of the ways the structure of our live streams are going to change starting in the new year. And so, Chris, I was hoping today you could share with our audience what that'll look like so that you guys can start to think about and plan out both live streams, but also content questions and give us feedback on what you want to hear.
Yeah, no. So obviously we're really excited for the live streams in 2025. As Liz has announced, she is pregnant with twins. She's going to be having them in February. So she has to take a little bit of a step back. As anybody knows who is a parent, Liz is having 4 under 4. So it's going to be real challenging. Plus she's running one of the largest residential clinics on the planet. So she's got a lot on her plate and has to take care of herself as well. So the good news is every first Wednesday of the month, same time, so 12 noon Eastern, 9 here on the West Coast, we're going to continue with Liz and myself doing Ask the Expert. So we'll both be here to do just what we did today. We got through so many pre-submitted questions as well as live questions. It's really all about you on that first Wednesday of the month. How can we answer your questions? What are you struggling with? Can we provide resources? Now, I'm happy with that because Liz is a familiar face. She's been doing this for a long time. You guys love her. So it'll be great to kind of kick off each month with Liz. But once again, she has to step back. She's having twins. We get that. The second Wednesday of the month, we are going to feature a psychiatrist. We get a lot of questions about medication, about TMS, about the latest of psychopharmacological interventions. And Liz and I, and you may know this as well, if you see a clinician, we are not licensed to be able to answer medication questions. And so having that person on the second Wednesday of every month, they're going to be able to answer those questions and talk about different things coming out in that field. Here at the IOCDF, we have amazing special interest groups. They are groups that focus on different aspects of OCD. We have perinatal OCD special interest groups. We have body dysmorphic disorder special interest groups, autism and OCD, and others. So we're going to feature a clinician from a special interest group on that third Wednesday. Nobody's available. We also have great IOCDF clinical advocates and IOCDF clinicians that run affiliates. So we'll kind of use that as well as backup. But we really want to feature some of the great work people are doing in that space. And then finally, on the fourth and final Wednesday of every month, we're going to feature just a guest who is a person in our field doing great work. Have them come on. Maybe they'll talk about a theme. Maybe they'll just answer questions. But for instance, having Allegra Castens on pretty soon, it would be like that on the fourth Wednesday. Somebody in our field that's doing great work. So that's what you can expect every single week. We sometimes have a fifth Wednesday of the month, so we'll figure out that. I know I was talking to Liz Lindley, maybe featuring one of our global partners, or if the IOCF has a big announcement, we could do that. But that way you kind of know what to expect each week. What I also want to say is every single week, we still are going to answer questions. So don't think that if you come a week, you have to just sit there and watch and not be able to engage. These are your live streams. We want you to be interactive. We want you to engage. And we're super excited about having you each week. And we're going to make it all about you. So keep hanging out with us every Wednesday, 12 Eastern, 9 a.m. Pacific for the live streams for the Ask the Experts and Lunch and Learns.
Couldn't agree more. Yeah, we're really excited, and we feel like this new structure is going to help organize and answer to a lot of the content you guys want. We hear a lot of folks wanting more medication-specific questions, so having that dedicated time with a psychiatrist every month is going to be amazing. We'll still have our live stream, which will be Chris and I to answer questions, and then, of course, being able to have a guest on for a special topic, and then being able to highlight all the incredible work IOCDF folks are doing, and hopefully that means having some of you guys on is something we're really excited about as well.
Yes. I'm excited about 2025 with the live streams.
So excited. Same. So good to see you all. We love you guys. We're so grateful for you. I hope you have a wonderful Thanksgiving. And what I will say is I am grateful for this community because I really do believe this community is the best community out there in the mental health space.
Yeah, and what I want to say is thank you for being with us today. We got through a lot of questions. We hope we gave you some direction, some support. We love hearing success stories. So thank you for sharing that. And thanks for being such an incredible community to each other. We had a great stream today, and it was all because of you guys. And it's always great seeing Liz. Make sure to check out Anxiety Society podcast, especially if there's some challenges that you're going to have as you see your family, or maybe it's the opposite. You don't have some family and you're really struggling. So there's a lot of resources. And never forget, go to IOCDF.org for all good things OCD. And if you can, this weekend, we're having the online OCD conference this Saturday and Sunday. So if you go to IOCDF.org/online OCD conference, there's more information on that. We hope you have a great rest of your week, and we'll see you this weekend if you come to the conference. Take care.
Yes, see you at the conference. Bye, guys.